Everyone, we'll discuss about periodontal abscess today. So periodontal abscess is I'll go with these contents: introduction, definition, classification, etiology, and microbiology pathogenesis, diagnosis, and the treatment of this periodontal abscess. So to introduce a periodontal abscess is a localized collection of pus where pus accumulate at a particular point where tooth is pathologically affected. So to this we have a definitions of International Conference of Research and Biology of Periodontal Disease and Karanza both define a periodontal abscess as a localized collection of particular pus with circumscribed area without a lining. If it is a lining, then it is called a cyst. Because it is not a lining, this is called circumscribed area, not a circumscribed area where we got a discrete portion of collection of pus, that is called periodontal abscess. So prevalence, coming to prevalence, 3% of third most frequent dental emergency, where representing 7 to 14% of cases are affected with periodontal abscess, and it affects the prognosis of disease, and it is reported by Gray and McLeod as 37% of these cases have all the periodontal pathology cases where it land up in periodontal abscess. So coming to classification, it has 3 classifications based on duration. One is duration, either it is acute or chronic, based on number, single or multiple, and based on location, whether it is gingival abscess or the periodontal abscess. Okay, based on etiology, it is periodontitis related or non-periodontitis related. So coming to periodontitis related, it is active periodontal destruction, exacerbation of chronic lesion, or post-therapy periodontal due to any iatrogenic effects like scaling or any post-surgery, and post-antibiotic. Some are allergic to antibiotics, so they land up in broad example in broad spectrum antibiotics, they land up in periodontal abscess. Multiple abscesses are seen. So coming to 4 types of abscess, the one is gingival abscess, second one is periodontal abscess, third one is periapical abscess, pericoronal abscess, combined periodontal and endodontic, lateral periodontal abscess. Gingival abscess is present only on the gingiva, and pericoronal abscess which is surrounding the 8 region, and combined periodontal abscess is like endodontically compromised tissue either with a periapical lesion along with the periodontal abscess. So lateral periodontal abscess is we confined only to a particular periodontal or the periodontium, like cementum or the periodontal ligament. So non-periodontitis related abscesses, impaction of foreign body, orthodontic devices like separators, they land up in periodontal abscess, and root morphological alterations like root discrepancies, fissure root tears, endodontic perforations. You mean to say that lacerations or the ledges formation in the endodontic treatment may land up in periodontal abscess. So coming to etiology of periodontal abscess, etiology can be divided into environmental factors, microbiological and other factors. Environmental are localized factors like periodontal pocket, pre-existing pocket, or the deeper and narrower pockets where in compound or complex pockets we can see this abscess. So microbiology, most of the prevalence of microorganisms are mostly anaerobic antimicroba. So P. gingivalis, where its prevalence is 50 to 100%, and organisms of red complex like Fusobacterium nucleatum, Bacteriophorcytis, P. gingivalis, and P. intermedia. So coming to this articles where Herrera et al. In 2000 said there are anaerobes resembling periodontitis microbiota, and Hashimoto et al. Other microbes along with the red complex like Fusobacterium nucleatum are present along with the spirochetes and A. So there are virus also seen in like cytomegalovirus and Epstein-Barr virus. So other local factors are where in popcorn husk, impacted food, fish bone, toothbrush bristles, and irrigating devices. So as diabetes is a 6th complication of periodontitis, even that land up in multiple periodontal abscess, like where the reason can be due to decreased chemotaxis or altered collagen metabolism. So pathogenesis of this periodontal abscess, likewise in periodontal pocket, you have entry of microbacteria into the soft tissue wall, trauma to the orifice or the attachment, then formation of intercellular infiltrate and destruction of connective tissue, like collagen will be, along with collagenases, it is destructed, and there is localized accumulation of pus there, pus formation, and decrease tissue resistance, and virus and bacteria will come in contact with that particular fluid or the pus, increasing the size of the tissue. So histopathology, where we can see normal oral epithelium, lamina propria, where you can see this intense foci of infection, intense focus of infection, and mass granular acidophilic and amorphous deferens are seen. So clinical features, where in clinics we can see this acute abscess are with localized red ovoid swelling, periodontal pocket, mobility can be seen or mobility is not a factor for periodontal abscess, tooth elevation in the socket, and exudation is either it can be pus or any infiltrate present, and elevated temperatures on the particular localized area, or with the multiple abscess in diabetes we can see the systemic increase in the temperature also, and regional lymphadenopathy, either subgingival submandibular lymphadenitis can be seen. So chronic abscess, no pain, dull pain, and patient won't be feeling this chronic abscess because it is with a longer duration and localized inflammatory lesion and slight tooth elevation. So as the acute abscess will land up in the chronic abscess, we can see the fistula and sinus formation at the adjacent tooth or the apical region of the particular tooth. So even and in Herrera, in a systematic review, he said blood and urine samples, they reported 30% elevation of leukocytes, and elevation is seen 20% in neutrophils. So differential diagnosis, when a case comes in clinics where periodontal abscess is seen, the similar clinical features are seen in periapical abscess, manifestation of systemic disease like diabetes, incomplete tooth fracture where the half of the tooth is fractured and the particular part will be swollen, that can be with differentially diagnosed as periodontal abscess, and pericoronitis and periodontal cysts like TEJ ruscets. Management of periodontal abscess, where the treatment lands up in two particular portions, one is non-surgical and the surgical. Non-surgical is localized, whatever the local factors are there can be removed. The periodontal treatment usually includes two stages. One is management of acute lesion or appropriate treatment of the original or the residual once the emergency situation has been controlled. Like you can see on a case there, management of acute lesion, where you can see the localized pus here, and incision and drainage is done, and after incision and drainage any localized collection of any granulation tissue can be removed with the scaling and root plane. So after this non-surgical or the non-surgical approach, you go to the surgical approach, where periodontal surgery, like you do a pocket elimination or the reduction thing, and after if it has any hopeless prognosis, you will end up this part in extraction of the tooth. So antibiotics which are incorporated along with the mechanical therapy and the surgical therapy, one is amoxicillin. If the patient has penicillin allergy, we will give a clindamycin with a loading dosage of 1 gram and then 500 mg for 3 days. So some of the others, like they tested along with the amoxicillin, they tested metronidazole, tetracycline, and where these pain levels are controlled by a pain scale 1 to 10. So based on the patients, they come to a conclusion that these are also effective along with the mechanical therapy. If at all surgical, and these two interventions are for surgical. One is gingivectomy and the surgical flaps. So when it is a rare case where there is no periodontal involvement or any pathology behind it, where you can see clenching of the tooth end up in clenching abscess. Like here you can see the swelling there, where it does not have any pathology behind, only the clenching of the tooth land up in, you can see this there. You can see here, you can appreciate that swelling there. This is before treatment and after treatment. So recent studies, even the orthodontic will cause periodontal abscess, where if untreated periodontal abscess may lead to necrotizing fasciitis. Orthodontic elastic separator which is placed here, it is induced a periodontal abscess over there, and even the separator here. You can see the separator and even separator. So to conclude the class, periodontal abscess once diagnosed can be treated either with non-mechanical therapy or the surgical approach based on the extension of the lesion and the severity of the lesion. These are the references which I took. Thank you.